late, so we might have given, there you go, allowing people to enter. Welcome everyone to today's Byrne Lecture in Health Sciences with a talk by Professor Tom Shakespeare titled COVID-19 and Disabled People, Triple Jeopardy. We'll give people 1 more minute or 2 minutes to join for late arrivals and then we'll start. Thank you. Welcome everyone. We're giving people 1 more minute to join. I see some familiar names. Welcome colleagues also from SPF in Ottawa. Nice that you could join. Okay, welcome again, everyone. Thank you very much for joining for today's Byrne Lecture in Health Sciences with a talk by Professor Tom Shakespeare titled COVID-19 and Disabled People, Triple Jeopardy. With some presentations of this year's lecture series, we attempt to shed a light on the interaction between science and health policy and ways that we can improve that dialogue between the two. And in the end, an implementation of evidence-based or evidence-informed policies. So during the series, we already had one talk by the former head of the Federal Office of Public Health, Professor Thomas Feldner, and he talked about independent scientific advice to policymakers before, during, and after the COVID-19 crisis. So this was more a macro level and also an insider's view onto mechanisms and processes into the knowledge translation and patient dialogue. So today we have the privilege of welcoming a renowned expert in disability research, among many other things, to share his insights with us. And I was just advised with Tom to not to spend too much time on his bio. But I got to know Tom ways back when he was still working with WHO and working on the World Report on Disability and international perspectives on spinal cord injury, and very fond memories going back to that, and him being a very large influence and teacher on my knowledge about disability and health policy. And you all have the bio shared with you on the flyer. But to mark 1 or 2 things about Tom, I think really the special thing about Tom is that he is an expert in many fields, also in the arts and not only disability research. He's been an advisor to the National Council on Bioethics, and he's currently also chair of Light of the World UK and vice chair of Light of the World International. So despite his a lot of work done in disability research, he also appears as an advisor to policy. And I just heard right after this talk, he'll be on British radio giving much needed advice to policymakers. So with that, before I hand over to you, Tom, to learn about your research, I would like to share some housekeeping rules. So we would like you to hold back with your questions to the end of Tom's presentation, which will take about 45 minutes. I'll be tracking the comment box, so we'll be able to catch all the questions there as well. And Tom will be presenting without slides, so there will be no visual distraction from any fancy slides that he's made. Just to bear that in mind. So with that, Tom, I hand over to you. Thank you very much.
Thank you very much, Per. It's great to be back with you, with my colleagues from Swiss Paraplegia Foundation, and with everybody in Bern, which is my favorite capital city of any city in the world. I love it. I was most recently, my only trip recently was to Zurich, and it's only sad to me that I couldn't get to Bern today. So I thank you for your patience with me speaking English, and I'll try not to speak too fast. I also thank you for your patience that I don't have slides. Literally, we have finished the paper that I'm presenting to you this week, which is why I haven't converted it into PowerPoint slides. But there is a real lack of data in this area about disability. And Per mentioned that I'll do Radio 4 later. I was on BBC TV at lunchtime, and it shows you that there's a real need for more understanding. Today is published from the Office of National Statistics, more data about disability. They're using 2011 census data to determine who is disabled. And we know in the 10 years since then, many more people will have become disabled as they get older. So it's out of date. What we learned today is that there is raised risk for people with disabilities. 3.1% raised risk for men, 3.5% raised risk for disabled women, 3.7% raised risk for people with intellectual disabilities. And one of the things that we know about people with intellectual disabilities is that, for example, some groups like people with Down syndrome, because of pre-existing autoimmune disorder, are at risk of dying of coronavirus, of COVID-19. And what's interesting from Italian data is that people with Down syndrome are dying much younger than other people. So the average age in this Italian cohort was 52 age of death for people with Down syndrome with coronavirus. Age of people without Down syndrome was 78, 52 versus 78, so dying younger. And when I say that there is a triple jeopardy, I'm referring to three things. First of all, people are more likely to contract the condition, COVID-19. Secondly, there's evidence that people are more likely to die once they have the condition. And thirdly, there's a social pandemic of disadvantage that is consequent on the condition, because there are lots of problems with how people are coping or changing their ways of life in order to protect themselves from COVID-19. I've said, that I'm not an epidemiologist, I'm not a public health doctor, so I'm not going to go into why people are more likely to die. But we do know that obviously half of all disabled people are over 60, and age is a risk factor for a bad outcome from COVID-19. We also know that many people with disabilities have comorbidities. And we know that diabetes, cancer, autoimmune diseases, obesity are all risk factors for bad outcomes from coronavirus. So I'm not going to dwell on that, but I am going to say a little bit about why people may be more likely to develop the disease. And if we think about it, social distancing is very hard for disabled people. Many people live in congregate living. And the ONS data, Office of National Statistics data published today, says that the single highest risk factor for people with intellectual disabilities was congregate living. So this tells us two things. One, that we should try and deinstitutionalize, get people out of institutions. And secondly, that as of now, people, particularly people with intellectual disabilities, should be a much higher priority for vaccination. And at the moment in Britain, we have got to the group 4 vaccination priority. And they've done everybody over 70. And the next group is group 4, and that includes everybody who's on the learning disability register. That's about 250,000 people. And we hope that they will be vaccinated imminently as a priority in group 4. But many countries do not prioritize people with intellectual disability for vaccination. And so I think that we need, in Britain and in the European area, we need to show why it's a priority, how to disaggregate, how to get it right to save lives. And we hope, therefore, we can influence policy in other countries. So as I say, I'm not going to dwell on why people do badly. I will say a few more things about how people are more at risk, because it's not only people in congregate living, it's also people, many disabled people rely on social care. So it may be their family, it may be a paid care worker, or it may even be a personal assistant, but they need other people to help them. And a lot of this care or assistance is hands-on. It's very difficult to socially isolate if you need physical help to do things. If you need somebody to cook your meals, they're going to have to come into your house. If you need somebody to get you out of bed, they're going to have to come into your house and probably help you out of bed physically. So very difficult. And think about people with visual impairment. The whole way that you get about is by touching things. You may not see who is around you, who needs that 2-meter distance to keep themselves safe. When you shop for things, you pick things up with your hands to feel them and make sure they're what you want. None of this is very conducive to social distancing. The guide dog does not understand social distancing, will take you to stand right next to somebody, not realizing that that's not what you're meant to do. So that's why I make the case about the problems of 1, worse outcomes, 2, more likely to get it. But what I want to talk about today is the pressure that the pandemic puts on already overstretched services. And there's lots of evidence from Britain of the difficulties that disabled people face in the United Kingdom. Difficulties of contractions in welfare benefits, reduced spending in adult social care, a reduction of nearly 10%. There is an overburdened service, more older people, more disabled people, less money for it, tighter eligibility criteria, and an increased reliance on informal care. So there's already a significant problem, which in the pandemic has been made worse. Lots of disabled people's organisations in the UK have done some studies. Glasgow Disability Alliance, Greater Manchester Coalition of Disabled People, Inclusion London. And what they've sort of done is to phone their members. They put together a sort of more anecdotal study. We've done something different. Funded by UKRI, which is the major UK research initiative, we've done qualitative interviews with 69 disabled people and 28 disability organisations in England and in Scotland. So we've got lots, 1 hour long interviews with them. And we're going to do it in 2 waves. I'm reporting on the first wave. And literally this week and last week, we've been phoning people up or doing Zoom calls to get second wave data to find out what it's really like. And I'll just say a few things about the second wave when we've finished. So 69 in-depth interviews, including with 11 carers of disabled children, mostly, as I say, around Glasgow and around London, but also in the rural areas. We failed to get enough Black and minority ethnic representatives. So there's not a good coverage of this population, I'm afraid. We did try, we have some, but not nearly enough. And so, you know, the numbers, yeah, I could give you the numbers. So for example, 8 people with autism, 5 people with a cognitive impairment, which includes things like dementia, 19 people with intellectual impairment, 18 people with mental health issues, 33 people with physical issues, 15 people with sensory impairment. So that adds up to 98. Obviously, many people have got 2 conditions or 3 conditions. Now, what did they say? And we did thematic analysis and all the rest of it. We have a large team of people. We exchanged transcripts and analyzed them together and collaboratively and had a code book across the whole study. What did they say? Well, I just want to quote the CEO of a large disability organization. And they said, I mean, without being dramatic, I think it's been catastrophic. I think it has taken existing inequalities that disabled people experience, and it has magnified them and exaggerated them. So what I want to talk to you about in terms of this really difficult situation is 4 themes. First of all, I want to talk about how the pandemic disrupts people's routine. Secondly, What about social care? Where is social care? Thirdly, I know we're interested in new technologies. Let's talk a little bit about that. Finally, what do disabled people say when you ask them, has this been well handled? Have you heard clear messages? And I think all of these 4 areas, plus the underlying jeopardy of risk and poor outcome, contribute to policy relevant messages which we feel should be heard. So to start off, the disabling disruptions. Now we know that disabled people have a narrower margin of health. We know that disabled people use the health service more, and therefore any disruption to health and rehabilitation services affects disabled people more. Disabled people also have a higher risk of mental health problems. And again, a pandemic which generally increases mental health issues across the community may have a particular impact on people with disabilities. So what we're finding is, at least at the start of the first wave, all the routine support was cancelled or went online. Physiotherapy, speech and language therapy, occupational therapy, all of these were suspended or cancelled or postponed. It didn't really work to do them online. So the problems of the epidemic, I've got a physiotherapist friend, and she goes to support children with cerebral palsy. And she says, look, I'm standing at the bottom of their road, shouting to them about their stretches and the work they should do to avoid contractures. I need to be really hands-on, seeing what they're doing and feeling where the muscles are. I can't do it from a distance. So it's a real problem. And, you know, what does it mean not to get rehabilitation, not to get assistive devices? It means problems of functioning. It means losing strength. It means not picking up on the complications that might be consequent on health conditions. For disabled children, it means lacking education, not being socialized, not having those developmental possibilities. I speak to older people with dementia, and these are not people with very extreme dementia, people with early onset dementia, but they say we lack confidence. We don't feel that we can now take the train like we previously did, travel independently like we previously did, because it's confusing. And I haven't done it for a while, and I'm not sure if I'll ever do it again. So a lot of people really impacted. And I told you about, it's not just physical health, it's also mental health. So this is a lady who has mental health issues, and she says, I can't go out for fear of dying. And then when I do go out, I'm running. I'm moving away from other people quicker. So this lady has got obsessive compulsive health anxiety. And of course, the pandemic makes it worse, makes it much worse. Social distancing, I've mentioned the problems for blind folk, but this guy is saying to us, I'm missing out. You know, it's serious. It's like missing out the shaking hands with people and giving them a hug and things like that. As a blind person, I'm missing out on all that because of social distancing. People who, with guide dogs who are not going out because the risk of bumping into people, because of course they can't see them, dogs are not trained in social distancing, said this person. They are much worse than before. People who are deaf and hard of hearing, the face mask that we all use, you can't lip read. There are very few transparent face masks available for people. And I said already the problems of disabled children. When online learning resources were made available, when schools were closed in the first wave, those were made available for non-disabled children, but only as an afterthought were they made available for disabled children. And so what I'm trying to say is that often disability is an afterthought. It's something you do after. And given that I argue that disabled people should be a priority and are at particular risk, if your policy is to do the mainstream and then go, oh yeah, disabled people, that's not good enough. And remembering that disabled people make up 15% of the population. That's a lot of people who are losing out. So for example, PPE, personal protective equipment, you know, the masks, the gowns, the gloves and everything else, They were, of course, available in a hospital environment, but they were not immediately available in a care home environment. And then finally, and there's a lot of deaths in British care homes, and then finally they were available in a care home situation, but they were not available in domiciliary situations, and people who were employing their own personal assistants, it was difficult to get PPE, and voluntary organizations did a lot of good work in sourcing that for them. And sort of symbolic of this idea that disabled people are an afterthought, every day at 5 o'clock, the Prime Minister and the health chief give a broadcast. It's never been sign language interpreted. And in a way, you know, there aren't that many people with sign language, but equally, it's not difficult to sign language interpret the Prime Minister. And if you do so, it sends a really good message. And if you do not do so, it sends a really bad message. So this deaf person said to us, you know, what do you think you've been adequately considered, we asked? And he said, no, certainly not, and definitely not British Sign Language users. Lowest of the low. We're right at the bottom of their list and falling off it. So lots of people who feel that they have been at risk of being forgotten. The second area I wanted to talk to you about was social care. And of course, social care is really important for many disabled people. And because of two things, the pandemic and the protective measures to stop people contracting the virus, they've been thrown back on their family and informal care. It's almost like the social care clock has been turned back to the 50s or 30s or something. The family, once more, for many people, are the unit which cares. And there's two major reasons for this. First of all, a lot of social care services, day centres, day services, lots of social care has been cancelled, put on hold, or severely limited. And secondly, some people are just anxious about too many people coming into their home. And they've said, we don't want social care, our family are going to do it. I spoke to a gentleman and he had both physical impairment and mental health condition, as did his wife. And their sons, these people I suppose were their 60s or something like that. And their sons who had been furloughed, their jobs had finished, came back home to live with them to look after their parents, to support their parents. And that's all very well. That's understandable. They didn't want people with potential risk in their home. But the problem is that after the pandemic, surely these sons are going to go back and get jobs. The older couple are going to be left without support. And they've told social care they don't need support. So we worry about the future. People worried about the future. We had one gentleman in Scotland, he said to us, I've been stuck upstairs for 14 weeks because my stair lift has broken down. The local authority are arguing with me about replacing the lift. They want me to live downstairs, not ever to go upstairs. So a real problem for him. This gentleman, Michael, who's autism, an intellectual disability, he was supported to live in his own home independently. But come the pandemic, he moved back in with his parents and his family members have been giving the support. And you might say that's all very well, but he's not used to dealing with a family. He's not used to all these people. And what I'm told by his sister is that his behaviors, repetitive behaviors, physical lashing out, all the rest of it, he's really deteriorated in an unfamiliar environment with too many people, with no day centre, with no core support. It's stress. He's very stressed and he's reacting very badly. Often social services have been absent. One person said they're just not answering their phones. You just sit and hope for the best that they phone you. So people have been without funding. They might have been offered phone support. One person said that his support had been reduced from 12 hours a week to 1 phone call a week. So really difficult. Respite care, not available. That's short break care. So it's a sort of residualist state. The family is most important. And often juggling trying to work, doing the care, trying to be teachers as well for any children in the family. Really difficult. What I wanted to quote here, and my colleagues wouldn't let me, but I can with you, is the Italian Marxist writer Antonio Gramsci, because he was talking about the revolution in Russia. And he said what the revolution revealed was that civil society, that is, everything beyond the state, was primordial and gelatinous. And I love that phrase. So just hold that phrase in your mind. Civil society was primordial and gelatinous. Because I think that this pandemic reveals that for people with intellectual disability in particular, civil society is primordial and gelatinous. That is to say, the civil society that people have, the association people have, the friends they have, the going out they have, is entirely artificial. We create it for them with our social services, with our voluntary services, the day centre, the drama group. It's about funding and support workers being available. And then you remove the funding, you remove the support workers, and the person does nothing. They stay at home, they watch TV, they never meet anybody, they're very, very cut off and lonely and suffer mental health problems perhaps, because the society, the civil society they had was really fragile, and it can be easily knocked down. So Basil, for example, who's a person with intellectual disability, said to us, on a Tuesday, I go to life skills, so life skills class, before the lockdown. But since the lockdown, I haven't been able to go because they wouldn't leave and all packed up because of the virus. I'm wanting to go back, but we can't because it's the problem with the buses and everything. So he's just isolated, he and his wife, isolated at home, not going out to their regular activities that they had before. And another person, a parent of a young man with cystic fibrosis, autism, and learning disability, intellectual disability, his mum said, well, he belonged to swimming clubs, disability football clubs, disability basketball clubs. He's day by day involved seeing lots of people and, the other people within his peer group. And that has completely stopped. Because of this, he very, very rarely did anything with us as a family because he found it too difficult and everything he did was one-on-one. So it's changed. He was going to a day centre, he was going to all these groups with other people, his peer group. Now he's stuck with his family, which he's not used to. And for many people, a big problem is boredom. So this woman who says, there's nothing I can do to make my day shorter. At the moment, I'm trying to sleep to get rid of some of the day. And in Britain, what's been really helpful in this crisis has been the third sector, what you might call voluntary organizations. So they've been trying to fill in the gaps. They've been going online. A lot of what they've done is actually give notebook computers like iPads so that people can go online. Because of course, if you suffer a digital divide and disabled people are more likely not to be online, then it can be very difficult for you. You're very isolated. So third sector organizations have done a lot, have had online services a lot. And there's, for example, this is called the staying in, the staying in. So that's a pun in English. You probably know this already, but an inn is like a bar. So the staying in is a place you go when you're staying in, when you're staying home. It's a pub for everybody in a way. So people come and they do Zoom and they chat, and they have lectures and they social connection, because otherwise they would be totally alone. They are so self-isolating. So it's a big problem. The third theme that we want to talk about is touch and presence. And this comes out of what we just said. A lot of what's been delivered has been online, which is wonderful and amazing. And it overcomes a lot of the barriers that disabled people face. So it's a good thing. And people who are blind can go online. And people who are deaf can see the type. And people who are autistic and don't like being too close to people are far away. And people like me who've got a wheelchair, we can get to the events even if it's in an inaccessible hall because it's all online. So that's really, really, really good. And a lot of disabled people are saying, hang on a minute, we always asked for this. This is really helpful. And now you're providing it because everybody needs it. Why isn't it been like this for a long time? So as long as you're online, as long as you can get online, it's a good thing. But I wanted to say that online access can do many things, but it can't replace human touch and togetherness. Touch is central to the work of primary care doctors, health workers, rehabilitation therapists, social care workers, children in school with their peer group, adults at work. You know, this connection, this togetherness is really, really important. So I think this pandemic has shown both the possibility of the online world, like I'm talking to you today, which is wonderful, but it also shows the limitations. And there are many areas of life where not being able to sit in the same room with somebody, not being able to hold their hand is a real crisis. And one of our respondents said to us, you can't play pool on Zoom. And so what they'd done before they'd gone to the day centre, they played pool with their mates. You can't play pool on Zoom. And pool or anything like that is a really nice way of spending time and having a chat and being not pressured. You don't get that on Zoom. It's much more difficult. The fourth key message I wanted to share was about leadership. What we've heard a lot in the UK is keep the vulnerable safe, keep the vulnerable safe. We must keep the vulnerable safe. But I think in Britain, they have actually cut services to vulnerable people. I've told you about social care cuts. One of the ways that it's been problematic, the way that Britain has messaged about the pandemic, is that they sent out shielding letters. They sent out letters to a proportion of the population who they identified as being at risk. But it was actually a minority of disabled people. And lots of people in our sample felt that they were at risk, but were not sent a letter. And this means two things. If you're not sent a letter, you're not on the priority group for support. You're not able, for example, to get online shopping automatically. So you're in a queue with everybody else, which could mean you don't get your groceries for weeks. And the second thing is what we call responsibilization. Sorry, I can't even pronounce it. Responsibilization. And what we're saying is that people are not told that they should shield, but think they should. The responsibility is back on them. They are made responsible for their own health. Now, in a way, that's a good thing, but they feel that they need to do it off their own back. They would rather somebody talk them through what they should do. A lot of the 5 o'clock broadcasts on the BBC have been about the death rate, who's died. And what's interesting in the UK, and I don't know if it's the same in Switzerland and other countries, is that it said so-and-so number of people have died, but most of them had pre-existing conditions. And that's like saying to the majority, don't worry, you're not disabled or you're not chronically ill, you're okay. But what's the message to people who are disabled and chronically ill? Oh, most of the people who died are like you. Doesn't make you feel any safer. So there's a messaging issue around there, which is problematic. There's the whole thing about vulnerability. There's a whole debate about vulnerability. So we now say CEV, clinically extremely vulnerable, because individuals who led full, rich, normal lives did not want now to be called vulnerable. But at the same time, they did want to be priorities for vaccinations. So I think there's an issue here, but the word clinically extremely vulnerable seems to be acceptable. So that's what's used now. There's been a difference between the UK and Scotland. You know that Scotland is a devolved administration. The Scottish First Minister has Nicola Sturgeon, has held daily briefings, been very clear, no messing, very helpful. Whereas in Britain, the Prime Minister has not been very clear, has reluctantly closed things down, has been slow to act, and has sent mixed messages. This is important for everybody, non-disabled and disabled alike. It's particularly important for disabled people. Imagine you're a person with intellectual disabilities. You need to understand. You need it to be clear. You're probably going to watch that broadcast every day. And maybe then you're going to phone your guardian and say, what did that mean? What should I do? The messaging has changed over and over again. And it's been very confusing for people. And voluntary organizations, community organizations, schools have had to change plans, sometimes really literally at the last minute, which has been very problematic. But they've done a really good job in getting the information out, converting it to easy read format, making it available through their web pages. But there has been a lack of trust in United Kingdom level information. Scotland has retained the trust, but not for the UK. And there were some really crass actions early in the pandemic which underscore this lack of trust. One was the National Institute for Guidance and Clinical Excellence. And they suddenly said, if you receive social care, you are in a high-risk group, you're going to be deprioritized. And it was like, hold on. You know, young people who receive social care shouldn't be deprioritized. It may be that if you're at the end of life and you require social care for everything, maybe there's an argument that you're frail, but you're not frail just because you receive social care daily. You are worthy, you're a valid citizen. Another example, there was a primary care practice, and they were putting do not attempt resuscitation, i.e. no CPR, on the notes of all the old people without any consultation. Now, this is a clinical decision and it's down to doctors, but the good practice is you discuss with the person before you add this to their notes. And old people particularly were very unhappy that suddenly they were regarded as being dispensable. And then there was a whole debate about ventilators and who would get a ventilator. And if there was a crisis, would disabled people get a ventilator? So there's 2 or 3 stories in the news which exemplified this worry. So let me conclude. We think that the pandemic has exposed vulnerabilities in British society. Not only are people at risk of a poor outcome, they're at risk of higher risk of contracting the virus, but also they're at risk of the measures that are taken to protect society from the virus. That's why I say triple jeopardy. Doing badly the virus, getting the virus, social response to the virus. And it seems to me that this is a model for how it might go in future, where we might have other pandemics, or where we might have problems of global climate change and how that impacts society. And I think we need now, in policy terms, to think of disabled people as part of society, as citizens worthy of protection, not as an afterthought. Think now so they can be included later. We did only research in England and Scotland. It may be different in Wales and Northern Ireland. We didn't recruit enough people with minority ethnic backgrounds. We didn't recruit enough people in care homes. But we know other people have done research in care homes. We know there's been a huge impact in care homes, and it has been badly managed. Not all of our people had internet access. Most did, but we deliberately tried to recruit some who didn't. So there are limitations. We think policies need to be put in place, and we hope that other countries like Switzerland and other European countries are also doing this research and are also doing something about it. So we need to understand better communication. We need to make information available to everybody, which includes easy read and sign language communication. We need to say to people that we will respect your care packages. We will reinstate them and we'll deal with the backlog so that you get social care after the crisis. We think that this is sort of made wider the existing divisions. Disabled people are very fearful. This shows why things like day centres and other provision is really important for disabled people to come together, and these services shouldn't be withdrawn. We think that disabled children have missed out and need extra resources to catch up. They're already behind. This pandemic has made them more behind. we're worried about the health needs, about rehabilitation. I'm sitting in a new wheelchair. It's very unusual. I got a new wheelchair who's delayed by, well, I was first needed to get it a year ago. That was when I was entitled to it, but I got it yesterday, literally yesterday. So I'm very lucky. And what was interesting when I talked to the wheelchair technician and physiotherapist, they said lots of people aren't coming. They're fearful of coming to hospital. And we think there'll be a huge backlog and a waiting list after the pandemic ends. Loads of people with unmet need. So people will have lost function. We need to pay attention to that. We need to support the third sector, the voluntary sector. It's very precarious, but yet very vital to support disabled people and their families. We need to work with them as equal partners, not just as contractors giving us services. We need to reduce unnecessary reporting and administration. And we need finally to provide fair and long-term funding. So those are the immediate things we have to do. I think in the longer term, we need to overhaul the social care system. Properly funded, humane, responsive. Working collaboratively with disabled people and their organizations. We need to listen to disabled people who have been so much affected by it. We need post-pandemic social change. We need to learn the lessons that this pandemic has shown us. And those are lessons about citizenship. There are also lessons about data. I was talking to my colleague Hannah Cooper today, who's doing some work for Public Health England. And she says, you know, GPs don't even have the simple codes on the records. So they can say, if you're saying to them, how have disabled people experienced this? They can't say, because they can't disaggregate. It's not so easy to see who is at particular risk of the coronavirus. So we need better data, we need better awareness so that we can respond more effectively to the needs of disabled people. So I'll stop talking. Thank you for your patience. I hope I've addressed slightly why this is a policy relevant question, and I'm very happy to answer any questions or hear any comments that you have.
Fantastic, Tom. Thank you very much for this extremely interesting, but also extremely troubling talk and insights that you gave. So we'll open the floor for questions, comments, clarifications. You could just unmute yourself, Oscar.
Tom, thank you very much. It was a fantastic talk. I just wanted to talk to you about something maybe not within your realms, but I just wanted to discuss with you this issue. In England, things are a lot better than in many other places. I mean, maybe not during the pandemic, but before. And the public health system in England has been an example worldwide. What we are seeing right now with the pandemic in low and middle income countries is a lot of disabled people that are being abandoned in the streets. They just have no access to care, no social support, nothing. They're basically abandoned in the streets. So keeping that in mind and keeping the point number 4 that you mentioned in leadership, what can we do as academics to contribute more towards the leadership of defending the rights or the public health, putting as a public health priority the needs of disabled people during the pandemic, not just in England, but globally? Yeah. I think what we do in England in terms of science or what we do in Europe is having a global impact. There is a lot of people that are following what we are publishing. There is a lot of people that follow the guidelines that we introduce. How can we act and how can we contribute to that leadership, that global leadership for disabled people during the pandemic?
It's a very important point, very, very important point. And I realize that Britain is privileged compared to many people. We are doing some research in Ghana, India, Bangladesh, Zambia with disabled people to try and map this. And I think one way that we can show that disabled people are valued and important is to do that research, is to amplify that voice. And if we can get information, if we can get good quality data, whether it's quantitative or qualitative, we can amplify that voice and we can influence, I hope, policymakers. And as you say, we can see where are the particular issues. A second thing we can do is when we are funding interventions in the global south, and we can make sure those interventions are accessible to disabled people. Let me give you one example. the UK Aid from the British People or whatever, the Foreign Commonwealth Development Office, are funding an initiative called Health and Behavioural Change, HBCC. And we've been commissioned to evaluate it to see if it's accessible to disabled people. And it's basically washing hands and distancing and all the other things. And we're looking to see whether the measures that the government is funding are equally accessible to disabled people, are changed to be available to disabled people. So I think that's very good. I think that one of the problems is that, as you say, the situation of disabled people is very precarious. Just give you one example of that. We've done some research with young people with psychosis in Zimbabwe. And many of those, they don't have any money, but what they do have, maybe they are the cleaner for a richer person. Maybe they are the gardener for a richer person. Maybe they're the nanny looking after the child of a richer person. But now there's a pandemic, everybody is back home. Nobody needs you to look after their children. Nobody needs you to clean their garden or to drive their cars or anything else because they're home. So a lot of the people that we were interviewing weren't able to earn a living and they relied on getting money every day in order to eat. So they were back with their family and very socially excluded. So I quite agree with you, Oscar. It's a big problem and we need to amplify this voice and make people more aware of it. I'm sorry, I can't offer you more than that.
Thanks a lot, Tom. I fully appreciate it.
Other questions? Please just unmute yourself or use the chat function.
Is that Martin, Professor Martin, who wants to speak? Can I hear you? Are you muted?
You're a little faint.
We can't hear you, Martin.
Ah.
Okay, he's setting the backup. Okay. No sound, unfortunately. Maybe you can fix it and
or put it in the box. Put it in the
put it in the box. Yeah, exactly. Type it in.
Okay. So there's a question from somebody. How do you identify yourself as a professional or sometimes as a disabled person? Well, I think I'm both. I think I am a disabled person. I'm born with a condition. I acquired a condition, spinal cord injury. So I live it. But I'm a very privileged white male middle class person. So I can't say I'm representative. And what I try to do is in my work with disabled people and gather. I love doing qualitative research. So interviewing people, and of course Zoom makes this much easier. They're home all the time and I can easily talk to them. And to give them credit, they're willing to talk to me and my team. I think that I can have authority as a disabled sociologist, expert on the issues that affect the disability community. And I'm getting on Radio 4, BBC yesterday, because people take you seriously. And with sadness, the rest of my team are not. I wish they were. And it's not because I'm stopping them, it's because I'm the only disabled person and therefore I have more credibility. So I think people are willing to listen. I think it helps if you have good data and you've done the work, as our team have.
Tom, so maybe switching our view a little bit more towards the policy response, and you touched on some of that, and there's some other things that you might have wanted to mention, the second wave of the survey and what you're going to do with the data beyond the publication and then talking on the radio, maybe taking it to some other fora and discussing with policymakers. But these are extreme circumstances under which everybody is, and that now shows existing inequalities, as you said. Twofold question: does that not open a specific, unique window of opportunity to show how crass those inequalities actually are, to voice those concerns and bring those issues to the policymakers in whatever forum, whatever place you can? Mechanism processes then being a sub-question. And the second part of the question would be, might this have not been anticipated? So is there not a pandemic plan? The UK has one, I know Switzerland has one, it didn't work, but wasn't there a subchapter somewhere in that pandemic plan saying most frail population have sign language, make sure that people can get the messages and these kind of things?
You'd have thought so. I mean, Britain did an exercise as a country about pandemic preparedness a few years before what we've now faced. And guess what? It found that Britain was woefully unprepared to deal with it. And they did nothing. And then 2 years later, or whatever it was, pandemic struck. And guess what? They're woefully unprepared. And just things like, you know, we can't disaggregate the primary care data to see who is disabled and at risk. You know, everybody relies on the data that primary care doctors have, and there is no marker. There's markers for lots of other things. You can tell how many people have been vaccinated and all of the other things, but not, are you disabled and at risk? Not there. And so I think that we failed to be prepared. And all of the message of what I'm saying is that the disabled people have been an afterthought. There's been this triple jeopardy because people haven't thought of it. And just to take one example, some of you will shop online and some of you will go to the grocery and buy your stores in Migros or whatever else it might be, Coop. In the UK, somebody like me, I bought my vegetables online because I can't carry very much. And that was always fine. You know, I could book later in the week, they would come. The moment the pandemic struck and nobody wanted to go out, you could not book a slot on the grocery deliveries for a month. You know, so what to do? I was really upset. I'm a middle-class academic, and I wrote a letter to my local supermarket, and I said, this is outrageous. Why have you done this? I'm not going to be able to shop forever, and da-da-da-da-da. And guess what? The next time I tried that supermarket, they said, you've been put into the shielding category, you have priority access. So my one letter had made a difference for me, Tom Shakespeare. But what about all the other people who would never write a letter, who would never be coherent and explanatory of why they should be prioritized, and who would lose out? And some people are literally starving. And I think that there should have been, I mean, it's hindsight, but there could have been preparedness. And as you say, Per, this is going to happen again. You know, we are going to have, obviously, climate change. We might have other pandemics. We need to have a system. And it seems to me that Switzerland is very organized about many, many things, and is very prepared about many, many natural disasters. And we need to learn the lessons from countries like yours and situations that face people around the world to say, look, we need to think ahead. And then when the disaster strikes, we can protect the most vulnerable, because otherwise, you know, there's a triple jeopardy that affects them.
Thanks, Tom, and welcome Professor Thomas Sadner, who's just joined us as well, and talking about preparedness for the next pandemic. Professor Shakespeare just said that the UK government, and it's quite awfully visible, was extremely badly prepared for the pandemic, and also especially for vulnerable parts of the population, and that the UK might look to Switzerland for an example how if they could prepare for the next pandemic or other crises like the climate crisis. Very interesting point. I think the views on that are a little bit different in Switzerland, and looking at the reaction in Switzerland, how things went here, especially after opening a lot of the shops after the first wave, when many of the colleagues also on this call and in academia said, you just have to be aware of that big second wave is going to come, and it did hit Switzerland with force. But maybe also based on your experience, and I then want to open the floor for other questions, of course, particularly working with WHO and on the World Report on Disability, you were inside the system, so to speak, where guidelines were being developed. You were talking to policymakers, and you made a point about you have to have the data to make the message go into the media, but there are closed door meetings where things are being discussed, policies are made, guidelines are made. What would be the key messages or mechanisms you would need to see in place so that the evidence that you're gathering can actually be transported across this gap into the systems and the guidelines that need to be in place for the next pandemic?
I would say this because I'm a social scientist, but I think we need better data. When I was at the WHO, one of my tasks was to try and mainstream disability. And there were, as you know, there's something like 50 directors in WHO. And I saw maybe 45 of them, and they were very gracious. They all gave me an hour or 20 minutes or whatever it was. And I said, disabled people should be a priority, whether it's tuberculosis, whether it's emergency preparedness. What are you doing for disabled people? And I tried to get them aware of it. But what they all said to me, almost all of them, they said, where's your data? How do you know disabled people are a particular priority? They may not be. It may be women or children or older people. And so, then I went back to the desk that you knew and loved and desperately tried to find the data to prove what was my intuition for disabled people. So I had to have a mechanism. I had to have an explanation. And I think, as I say, we're lacking data about disability. So that's a first and foremost, because at least in the WHO and in Britain, and I'm sure in Switzerland, it all revolves around data. So, evidence synthesis, systematic reviews, reviews of reviews to show what we need to know, I think is really important.
Okay, thank you. Other questions?
Is that Professor Zeitner has a question, I think, or Zeltner?
Yeah, thank you very much for your presentation. And I was actually present, but didn't show my face during the talk. Thank you so much for this. And my question actually goes back to what you just alluded a little bit. I mean, most of the pandemic preparedness is actually focusing on physical health. I mean, yes. If you look through the plans, they are full of, how to prevent and deal an infectious disease. It's very difficult already to get in the mental health dimension. And you brought in now the social health dimension, and then, talking about WHO's perspective, we would even eventually want to bring in the spiritual health dimension. Now, if you had to give an advice to WHO or someone who is reviewing the pandemic plans, and all countries will go into it, what priorities or what focus would you put on when it comes to social health? Because we actually have not a single word of that in the pandemic preparedness plan, for instance, in Switzerland.
Yeah, and I think it's a real problem. And for example, in Britain, the data shows that in terms of depressive illness, which is about 5% of the population at any one time, during the pandemic, it went up to 10%. It doubled. Huge increase. And of course, people don't see anybody, they're left alone. And I think, again, sorry to personalize it, but I'm very happy to talk to people online. I use my brain, I write at my computer, I say hello to my neighbor, I'm absolutely fine. But many people, that's not a life they live. They don't do brain work all the time, they do physical work, or they meet people, or they're more sociable. And I think you're absolutely right that depression, obviously fear, anxiety, and the exacerbation of more serious mental illness caused by isolation and paranoia and so forth is a real problem which has not been dealt with. Now, on the one hand, there has been evidence, I think, that online therapy can be useful for some people. And some of the people we reported had done online therapy and it was great. But it is not the solution for everybody. And for many, what they want is to gather with others. And so I think it's, as I said in my talk, I think it's understandable why social care day centers close down immediately. But maybe there's ways we need to think about, can we do COVID-proof social contact? Can we do COVID-proof day centers or psychiatric consultations, or simply places and times for people to meet outside? I think a lot of disabled people's mental states were very improved when disabled people's organizations or new voluntary structures got together to connect them. I think human beings want to connect with each other. And if they can't do that, and if they're stuck indoors all day, they get very depressed and very unhappy. And when we know there's a digital divide, and many older people, many disabled people, many poorer people do not have internet access, do not have gadgets to enable them to dial in, we think that that's an increased risk. So maybe we should, some voluntary organizations, they had money in their budget for physical meetings, and they just bought lots of iPads and notebooks and literally gave them to their members, went around, here you are, here you are, here you are. Then they could log on and connect with other people. It was that important. And I'm sure they were right. I'm sure they were right. It was very important for people.
Great, thank you, Tom. There's one question from Thomas Abel in the chat. More data is of course welcomed. It can help, it will not solve the problem, unfortunately, as we've seen with other social health inequalities. What about a better understanding of policy agenda setting? So going a bit back to the mechanisms and processes.
I don't think data on its own will solve the problem, but I do think that many people, when you say this is a policy priority, say, where's your data? So I do think that, at least in Britain, I'm sure in Switzerland, is an issue. So I'm not a policy professional, so you will understand this much better than I. One thing that I think we could make a strong case for is that disability is not a minority experience. And Per and our friend Jerome Bickenbach at WHO were making this point very clearly. Not only is disability a risk that everybody faces throughout the life course, could happen to anybody at any time, most people will become disabled eventually as they become older. And most importantly, we said in the World Report on Disability, there's 1 billion disabled people in the world, and there's maybe 8 million, whatever it is, 9 million people, 1 billion people in the world. That means that every extended family has disabled family members, either a child or a parent or a grandparent who's disabled. So if we can say, and there's a lot of social concern about this, and so one of the ways perhaps we can get it up the policy agenda is to say this is not a minority experience, this is a human experience. It affects every family, and we've got to get it right. And a culture, a society that does not protect its most vulnerable members is not one that people want to support. It's not one that people respect. As I say, clear messaging, understanding that it's not a minority issue, evidence to show it's important.
You are alluding to
I hope they help.
Value question in that.
Yeah, value.
Okay, yeah. And then we need, I mean, then data is only partly helpful for this.
Yes.
We have seen this over and over again. You present the problem to politicians and then they say, well, come back when you have better data.
Yes, yeah.
Excuse, there's no doubt this is an excuse. And we come back with better data and again, nothing will happen. So I'm totally convinced that there has to be more research on the value systems, public health. And one of the lessons you said, unfortunately only in a side sentence, you mentioned lessons about citizenship.
Yeah.
In we need to be much stronger on this.
Yeah.
And bring in the citizens in this agenda setting. I mean, it's a bit naive to think that we, with our small facet or perspective, would change the whole system. I need that there needs to be a much broader movement, bringing in citizenship as you said, it will affect 15% of the population. I mean, there you have a starting point for increasing citizenship and the impact of the citizens on this.
Yeah, no, I agree. I would say that we can change things. So, for example, we changed the National Institute of Clinical Excellence approach. We changed Public Health England approach. So, there are measures that are taken that have an impact and have a real impact on people's lives. So it is possible in small ways. I don't believe that the policymakers are deliberately ignoring disabled people. I think sometimes they need the message to be clearly articulated, which we're trying to do now. I agree with you that it's a values question. And yes, citizenship and having better theories of citizenship, it's part of it. Yeah, for sure. Thank you for your perspective, Professor Abel.
So citizenship and clear messages. We're coming to the end of our session, but there was one question I think by Therese Stutz, please. If you would like to unmute yourself.
I think I would like to draw the attention on the importance of connecting and networking, because like you, Tom, I have the insight into the patient disability community, and I have the insight or the connection to the professional community. And I miss on both sides, or I think there is less and less intention to really do networking and connecting, and it is on both sides. And so it is also very difficult that you have an interaction between the community of the active patients or disabled or whatever and the professionals. And I think we
lost you, I think, Teresa. We lost that last.
You and so on and so on.
Yes, no, I think connection is very, very important. And so that we don't see professionals as the enemy, but we see them as people to work with and educate and learn from. And I think there's a real value in what we in England call experts by experience, that many people are experts by their research, by their clinical practice, and they have a great insight, and we need them. But we also have expertise by experience if we live with this all the time. And that collaborative approach where people learn from each other, I think is the right way to solve this and future pandemics. And it reassures people that, as Professor Abel said, that they will be valued and taken seriously. Now, friends, I really apologize, but I have to go because I have to do a BBC thing.
Tom, fantastic. Thank you very much. An extremely important and interesting talk. Sorry to all of you who I might have missed. I wasn't very conscious in catching the raised hands but I monitored the chat box. I think there is a lot to keep on discussing and keep in contact. I think there is a lot of interesting things going on here. There's a great interest at ISPM in the topic. So Tom, thank you very, very much again.
No problem. I will send you a copy of my text, and I apologize that speaking fast, people may have missed things. And then you'll be able to see the quotations and see what we've argued. I'll send that to Per, and then hopefully if you need it, you're welcome to take it from him.
Fantastic. Thank you very much, Tom. Bye-bye. Take care.
Thank you for having me. Bye. Good afternoon, and thank you for your attention.